Think about patient-centered healthcare. What do you think about with that? If you're a clinician, you might think of the 50-year-old female with diabetes, and when you think about patient-centered care, you might think about getting a urine microalbumin, hemoglobin A1C, an LDL, blood pressure, height, weight, screening for depression, checking smoking status, maybe colon cancer screening, mammography. Is that patient-centered care? Well, those are the quality markers with patient-centered medical home, and those are experiences, and we think that's good patient-centered quality care. But is it? I want to talk about a different concept called high-value care. Michael Porter talks about this in Transforming Healthcare. What is high-value care? High-value care is outcomes that matter to the patient divided by the cost per patient. Outcomes that matter to the patient. Now that sounds like patient-centered care to me. You see, quality is simply defined as a degree of excellence, a degree of doing good. But value is outcome-based. Quality is often process-based. Did we check this box? Did we get this test? Did we do this? Did we do that? But we don't have outcomes to go with that. So I'm going to talk about high-value care today. When we talk about high-value care, we want to talk about building relationships with the patient. Building a relationship, getting to know what's going on with our patient. So we're not asking the patient, what's the matter with you? We're asking the patient, what matters to you? We get beyond our own agenda as healthcare providers to find out what's going on in the patient's life. What's happening in their life? Their LDL cholesterol, their diabetes might not be the important thing in their life. What are the patient's goals, values, and needs? Not what are our quality markers we have to obtain. Everybody in life is seeking connection, purpose, and hope. All of us are. And all of our patients are seeking connection, purpose, and hope. And if they don't meet those, if they don't find those, they don't thrive in life. We don't thrive in life. We don't maintain our health. So by finding out what's going on in a person's life, what's going on with their family, what's going on with their job, what's going on in the rest of their life, we don't know about their capacity for health. We don't know if that LDL or that hemoglobin A1C or any of those things matter at all to them. So we do that by what I call building a relationship of hope. And that's the first thing we need to do. As clinicians, we need to build relationships, what I call relationships of hope. So people feel hope in life, so they find connection, so they find purpose. There's no boxes on our checklist for that. But when people find that, they thrive. Then they make lifestyle changes, then they live healthier. The second thing we do is share information. And to do that, we can talk about risk reduction, but what does a 50% risk reduction mean to a patient? What if I say I can reduce your risk of heart attacks by 50%, unless we know the baseline risk? What if I can reduce your risk of colon cancer? We don't know the baseline risk. So a 50% reduction to someone with a 2% risk means something very different than a 50% reduction if you have a 50% risk. So we need to know baseline risk. And this next slide is from work by Stephen Wollaston and his colleagues in New Hampshire. And these are baseline risks of people of various ages based on their smoking or non-smoking status. This one is females, there's one for males as well. And it tells their risk of dying of certain conditions in the next 10 years out of 1,000. So in this slide you can see that this woman, 50-year-old woman, has a risk of dying of breast cancer in the next 10 years of 4 in 1,000. And her risk of dying of colon cancer in the next 10 years is 1 in 1,000. Now most people see that and they're very relieved because every 50-year-old thinks they're going to die of breast and colon cancer. The risks are very low. You can also see that for a smoker, the risk of dying of some conditions such as heart disease and lung cancer is much higher than a non-smoker. Now I keep these charts laminated in every exam room, and patients are often looking at them when I walk in, and just looking at that one fact, smoker versus non-smoker, has motivated many of my patients to want to quit smoking because it's very powerful. So this is a starting point. This doesn't take into account their individual risk factors, their family history, their personal history, their past medical history, and their lifestyle. But it gives us a starting point so patients have a perspective from which to make a decision about things they want to work on. Now, once you know your perspective, we can look at specific conditions. So good studies show us that mammography, screening mammography, reduces death from breast cancer by 20%. Now, this chart helps patients see the data more clearly. As you can see, this was 1,000 women starting at age 50 screened for 10 years with mammography. And for the screened women, or the non-screened women, excuse me, there were 5 deaths out of 1,000 over 10 years from breast cancer. For the screened women, there were only 4 deaths. That's a 20% reduction from 4 in 1,000 over 10, 5 in 1,000 over 10 years to 4 in 1,000 over 10 years. But it gives you a different perspective of what that 20% means. Deaths from all causes of cancer were 21 in both groups. They weren't reduced with screening mammography. And it's interesting to note that all-cause cancer deaths were 4 times higher than breast cancer. What about the harms? Well, out of those 1,000 women, 100 of them had false positives, false alarms. They had more testing. Some had biopsies. They had a lot of worry and a lot of anxiety until it was found out they didn't have breast cancer. 100 out of 1,000 women. And finally, and most powerful to me, is 5 of those 1,000 women were diagnosed with breast cancer, treated for breast cancer with radiation, chemotherapy, and surgery. They didn't need to be treated. They were treated unnecessarily. Do we share with women before they get their mammogram this kind of information about the potential harms, as well as how big that benefit is? What's a bigger benefit? What should we also share with women? Exercise. Exercise has been well studied in the prevention of breast cancer and colon cancer. This slide from the National Cancer Institute tells us that physical activity can reduce breast cancer by 20 to 80%. That's much more than a mammogram. And the exercise is multiplied manyfold, because we also know from the National Cancer Institute you can reduce your risk of colon cancer by 30 to 40%. And we also know you can reduce your risk of heart disease, diabetes, depression, many other things with exercise. Can we ethically order a mammogram without talking about the benefits of exercise? Can we just check that box without talking about exercise? I don't think so. I think every woman deserves to at least know other ways they can also, whether they want to do it in addition to or instead of a mammogram. Another tool I like to use is the number needed to treat. And there's a website called thennt.com. It's got excellent slides on many, many different topics that are easy to share with the patient, and clinicians can use these. I picked one out here on statins and heart disease. This is taking statins for 5 years in people who have never had heart disease, so we call it primary prevention. This tells you the benefits and risks. So people that took statins for 5 years had no death reduction. No death reduction with the statins. You had to treat 104 people for 5 years with a statin to prevent 1 heart attack. And you had to treat 154 people for 5 years to prevent 1 stroke. This puts the benefit of statins in primary prevention in perspective. Patients can look at this, clinicians can look at this. Instead of looking at a number and saying, well, we give it to you because the guideline, the checkbox says to do so, we see this is the benefit. And what are the harms? Well, for every 50 people treated for 5 years with a statin, 1 developed diabetes. And for every 10 people treated for 5 years, 1 had muscle pain or muscle damage. Now you can give your patient a clear perspective from which they can make a choice, a rational choice. We often make our choices based on fear, or by someone else's recommendations, or by a guideline. Here the patient can make a rational choice, like we would with our investments, like we would with our kids' college education. We make a rational choice based on the pros and the cons. The NNT has many other charts. I just want to share briefly one other one. This one is great, because this tells about the benefits of exercise and balance training for preventing falls in the elderly. Now that's an outcome that matters to my elderly patients. They don't want to fall, they don't want to end up in a nursing home, and it saves money when they don't fall. We all know that. 11 people are treated with balance and exercise training to prevent 1 fall over a year time. That's an incredible number to treat. It's low cost. Look at the harms. Nobody was harmed. I do exercise and balance training with my patients, the approaching elders and the elders. I do balance training practice every day myself because it's something simple people can do, and it has high value care. It's outcomes that matter to our patients. I've talked about checklists a lot, and Atul Gawande wrote a book about checklists, which you may have read. Checklists are great when they're used properly, but if they're all process measures that don't have outcomes based, they don't really help us a lot. Just completing a checklist doesn't mean we're doing good care and giving better care. But there's a checklist that Shannon Brownlee has in her book, Overtreated. And it's a great tool to engage patients and to facilitate high-value care. And she has 5 questions. How good is the evidence that this test or this treatment or this drug will reduce my risk of dying or having the event? Is the test itself dangerous? Are there harms to this test? Could the test lead to my being treated unnecessarily? Does the treatment I face have side effects? And finally, and very importantly, can I make changes in my lifestyle and eating habits that might reduce my risk of getting this disease? These are the checklists that patients and clinicians can be asking to facilitate high-value outcomes that matter most to the patient. Transforming healthcare begins with all of us. It's not going to be legislated. There's not some leadership group that's going to do it. We all have to do that. Healthcare has 2 words in it, health and care. And I believe that the second word is critical to achieving this first word, health. I want to end with a quote by a colleague of mine, a nurse practitioner who said, people don't know care how much we know unless they know how much we care. Thank you very much.